Hi all, thanks for joining us today for the Consumer Engagement 101 panel session. I'm Sarah Ely from Health Translation SA and I'll be facilitating today's session. We've got 5 great panellists today who will share their experience in collaborative research projects so we can all learn from their examples. And after their introductions, we'll have around 45 minutes for Q&A. So feel free to pop questions into the Q&A box at any time, and we'll get to the questions that we can at the end, and we're due to wrap up around 1:30. So I just want to start by acknowledging that the Kaurna people are the traditional custodians of the Adelaide region, and we recognise the Kaurna people's cultural, spiritual, physical and emotional connections with their land. We honour and pay our respects to Kaurna elders, both past and present, and all generations of Kaurna people now and into the future. So briefly, who are Health Translation SA? So just a couple of rough stats here, is that it takes approximately 17 years for a discovery to make it to the clinic, and around 80% of research never leaves the shelf. So Health Translation SA, we were set up as an NHMRC accredited research translation centre to speed up the translation of the research discoveries into clinical care, and that's to try and bring down these statistics. We partner with 11 academic research and healthcare agencies, within which encompasses the breadth of health service delivery across South Australia, and you can see these logos of our partners down the bottom. So our vision is to accelerate the translation of research findings to improve the health of South Australians. And we work with our partners and stakeholders as an independent catalyst and broker to mobilise collaborations that address major health system challenges. We do this in a variety of ways, which you can see from this little table or diagram here. Working with policymakers and a whole heap in the education and training space, work with health services to improve care that patients are receiving, looking with researchers and research organisations. We do a lot of stakeholder mapping, making sure that projects are involving the right stakeholders. And then today we have a hub within the consumer and community involvement space. And so our portfolio in the CCI space involves a few different ways that we can help individuals, or teams. If you're watching this today and want some assistance in building partnerships with community members, then please get in touch with us. Agostina, Gancia and I work in this space at HTSA, and we can assist in a variety of ways. And at the end of this, I'll have our contact details. But now on to today's session. Why are we running this panel session? So in my 12-ish months of being at HTSA, I've heard many researchers say they've reviewed the theory of consumer engagement in research, but they're a bit unsure on how to apply this to their work, or that they don't feel particularly confident. Or they look at other people's research and think, oh, that's easy for them because they work in X space, but it's a bit trickier for me. So I thought having this session would be able to provide some inspiration for those who are yet to dip your toe in the consumer engagement world, or who are struggling where to go next. So I reached out to some people who've had a lot of experience in this space, and I'm thrilled with the panel that we've pulled together. And so firstly, we're going to hear from Carolyn, who's a research fellow at UniSA, and she's a senior physiotherapist in the Paediatric Chronic Pain Service Unit at the Women's and Children's Hospital. Gillian is a pharmacoepidemiologist who works for the Registry of Senior Australians, ROSA, at Summary. Mario is a valued consumer advocate for a range of organisations, including research institutes, universities, LHNs and not-for-profits. Shyam offers a unique blend of personal experience and professional expertise in consumer and community engagement. And Hannah works to predict and prevent the debilitating side effects of cancer in both preclinical and clinical research environments. So I'm just going to stop sharing my screen now. Excuse me. And so we're just going to hear from each of the panelists for a little bit. They're going to outline a little bit of their background and then answer a couple of questions. So my first questions are for Carolyn, Gillian and Hannah, but I'll start with Carolyn. Yeah, could you please, Carolyn, briefly introduce yourself and answer the following 2 questions? Why did you start engaging consumers in your research, and how has this consumer engagement benefited your research from your perspective, please?
Well, thanks a lot. Thanks for having me on, Sarah. It's been great working with Health Translation SA, and I'll declare that up front. So if anyone does need any extra tips or things, it's a great place for a first stop. My background is as a physiotherapist, and I was a clinical physiotherapist for at least 18 years before I went back and did a PhD. Actually, the consumer engagement I got when I was being a clinical physio informed the question that I had for my PhD. So I pursued that through PhD and then ended up with an NH&MRC early career fellowship, which allowed me to investigate mechanisms underlying chronic pain. And chronic pain has been my sort of lifelong trajectory to try and find out what it is that we can do better, because we're not managing people with chronic pain terribly well at the moment. And so that fellowship at the Adelaide University was pretty much all experimental and basic pain sciences, and continues on at the moment. So I've got a nice mix of basic pain science, plus now I've started again because I loved the consumer stories, and I think that informs my research in a much better way. I started back at the Women and Children's Hospital 1 day a week working in their chronic pain unit. And it was that particular scenario that actually started me engaging in consumer research, because in fact it's quite a tricky area to be in when you're dealing with teenagers with chronic pain, families. There are a lot of layers that go together with looking after teenagers in the clinic. And so we wanted to understand that situation better and to design a better model for looking after adolescents with chronic pain. And that was the why, because each stakeholder has a key to a certain piece of the puzzle, and we wanted to involve all stakeholders in the design of a new model for adolescent chronic pain care. So that's how I ended up starting into engagement of consumers, or community engagement. And the benefits have been great. So by talking to all the stakeholders, we've been able to build a straw man model of care, which is built on adolescent concerns with parental buy-in. And importantly, it considers the primary voice in the therapeutic interaction as the adolescent. So with family contributing decisions and feasibility criteria there. And continuing on with the stakeholder or the consumer engagement, we found all of these different options that have informed our model, help the research and the governance teams to consider resources that are needed to promote the model of giving the adolescent a voice. And that includes things like a clinical translator or a clinical resource for, like, a child life specialist. And they have these in Canada, but we don't have them here. And that would be a sort of person that tails with the family and with the adolescent to translate the information that comes through, so that they've got better understanding of the choices that they might like to make, therefore empowering the consumers within that model. And the possibility of therapeutic interaction, including friends, along to the therapeutic interaction, which is something that the adolescents were saying would be really helpful, because then that would help their community to understand a lot more about what's actually going on. Chronic pain is one of those very difficult to explain type of scenarios, and the adolescents often feel like they lose a voice. They often feel like they don't have friends at school, and then a whole heap of social and environmental changes occur, like not wanting to go to school and all sorts of developmental issues that are really critical at adolescent time tend to change and are difficult to make up for later on in the piece. Another thing that's happened is a less formal clinical environment has been reported by the consumers, both parents and adolescents in that instance, for where different activities, because you're a developing person, a developing human, and you've just lost, your capacity to dance or to do the things that you knew that you loved doing. And then they're saying, well, actually, how do we know where we're going to go? How do we know how to create ourselves again, unless we get the opportunity to go to different places and try different things? And so that's part and parcel of this model that has been developed with their input. And the final thing is that everyone in all community stakeholders in this instance have said that it's really important to have one person coordinating the care, because as any parent would know, you get, pillar and posted, sent to all sorts of different places, not able to kind of work out which direction you're meant to go in, which one's got more priority, which one actually has got like evidence behind it. And so one coordinator who could actually assist family and child or adolescent to go through has been a very important thing. So those benefits have come out of our consumer engagement.
Fantastic. Thanks, Carolyn, for providing that. Now we're going to go across to Gillian. And so just to refresh the questions there, a brief introduction, and then why did you start engaging consumers and what are some of the benefits you've experienced for your research, please?
Great. Well, thanks, Sarah, and thanks for inviting me to participate in the panel today. So my name's Gillian Caughey, and I'm the Associate Director at the Registry of Senior Australians at SAMRI. And we really, from our inception in 2017, had consumers as part of our overall government. So we're established through quite a large collaboration between all three universities, SA Health, clinicians, aged care providers, and importantly to consumer advocacy groups, HTSA and Health Consumers Alliance SA, and they don't exist anymore. But from that inception of ROSA, so we link all aged care and healthcare data to build a national registry so we can examine the quality and safety of care and provide high-level evidence to ultimately improve the health and well-being of older people that receive aged care services in Australia. And so it's really important that our research is informed by what priorities and what's really important to our end users, and our end users are older people. So as I said, we've got consumers embedded in our overall governance. And so we have now, we have 2 consumers on our overall steering committee. We have 18 members on that steering committee, and we also have HTSA represented on that. And importantly, we also established a separate consumer and community committee as well. And Mario, who's a panelist, is also a member on that committee. And, you know, we really thought that it was really important to have that opportunity, just to have that consumers having their own committee, that panel, and to be able to provide that voice to help us with prioritising our research. And we really wanted them to be able to promote and support that community engagement, obviously answer questions that are really important for consumers, and that interactive engagement of the end users with our research has been really, you know, quite a highlight of some of the work that we've done in ROSA. One of the things that we've really strived to do within our research is to have consumers embedded throughout the whole research life cycle. So often, you know, you might do studies and then you think, oh, we'll need to present it to a consumer panel. But by having our consumer committee, we ensure that, you know, from conception of ideas is really driven through the consumers. And so they're involved, as I said, in all stages. So we involve them in things like ideas, research questions, protocol development, engaging with our early career and mid-career researchers, and I'll share a little bit more about that. And also importantly, in terms of dissemination of our research findings and making sure that the messages that we want to get out to older people receiving aged care services are worded appropriately in a formative language that then can drive that impact in terms of having that consumer engagement and that ability to change practice and policy also as well. So we have grown in our research consumer committee as well with ROSA, with the growth of our department over the last few years, and we've gone from 8 to 12 members. So it's quite a busy consumer group. We meet 3 times a year. And then there's also sort of ad hoc engagement as well. So whenever we have a research publication, we try to develop infographics for translation and dissemination of our research findings. And so then we'll reach out to a consumer to get them to help be involved in designing that, and then the messages, the key messages that are really important from a consumer perspective about the research is, you know, what is it that we want to get out there. One of the really, you know, really successful and things that we're really proud of at ROSA is our early to mid-career consumer mentorship program. So we actually match a consumer member with one of our PhD students or an early to mid-career researcher for all work that we do. And this really then does embed that consumer engagement throughout all of the stages of their research priorities. And it's not just about setting those priorities, it's about talking about, the research findings. What does it mean? How would you interpret this? And just to really get that consumer perspective. We can sit, in our beautiful building here at SAMRI, but, it's really important that we actually are interpreting the results from a consumer perspective, what's important to them, what key messages are important for consumers to get out. And that program has grown. Now we've got 6 of our early career researchers involved in that. And the feedback's been really lovely in terms of that building a relationship, because it's not just about having a committee or having a panel. It really is about having a relationship with the members that then that really drives to sort of that higher level consumer and community engagement. Just one of the sort of, there's been so many fantastic reasons and fantastic outputs from our collaboration and highlights, but one of the more recent things that I like to share is that we actually have received our first 2 consumer-driven research grants last year. And they were both with our early career postdocs, Steph Harrison and Tess Fahanashidi. And these were ideas that were born from our research committee. So during our meetings, we'd heard the importance of there's not enough done to support carers of older people, when the carers in terms of, helping to support their loved ones, whether it's a family member or a friend, and then the impact that potentially having that carer and support person on health outcomes and well-being of our older population. So through those conversations, through those discussions, we then developed 2 research grants in collaboration with consumers. So we've got one of the projects was funded through the Stroke Foundation, and that's looking at the impact of having a carer on stroke outcomes. And then the other program is funded through Health Translation SA, which is a MRFFC grant, looking at the impact of having a carer on quality and safety of care that people receive in aged care services. So both of those programs of work are just starting this year. And I think, it was just a really lovely, journey from 2017 to now that we're actually doing, grants that are driven by the consumers and what their voice is and what the priority is. And I just, really wanted to highlight that as a really fantastic example of having those relationships with the consumers then led to sort of the grant funding, and then hopefully a really impactful program of work. We'll actually be able to provide that evidence to say, hey, having a support person, having a carer really does make a difference in terms of quality and safety of care and outcomes and well-being. And having that evidence base will then hopefully drive greater supports for older people to have carers and paid positions. So I think it really is an opportunity for us to sort of provide the evidence for policy and practice change. So I think I'll leave it there.
Oh, that's great. Really excellent about those couple of grants as well. Nice to see the evolution over, the 5 years of what you guys are doing. So thank you for that. And Hannah, so those same questions, if you could briefly introduce yourself, why you started engaging with consumers in your research and some of the benefits you've seen. Thank you.
Sure. So, I'm Hannah. I completed my PhD at the University of Adelaide back in 2016. I still like to consider myself an early career researcher, but I fear that I may be pushing that definition a little bit these days. I still feel early. So after finishing my PhD, which really focused on the sort of molecular mechanisms that cause gastrointestinal side effects of chemotherapy, so things like diarrhea, pain, bleeding, infection, I headed off overseas for a couple of years and did my postdoc in the Netherlands. I came back in 2020 in the chaos that was COVID, and decided it'd be a really good idea to start my own lab, which I did in 2020. And that is the Supportive Oncology Research Group, which is embedded into the precision cancer medicine theme at SAMRI, but I'm also employed by the University of Adelaide. So we're now a team of about 10 to 12 of us, mainly PhD students and one postdoc and some staff. And really our goal, as the name suggests, of our group is that we're tackling the diverse and many problems that people affected by cancer may experience as a result of their treatment. So we're looking at symptoms and side effects of treatment. And really our projects or our work spans anything from the bench right to the bedside. So we do in vitro lab-based work where we model the blood-brain barrier and how chemotherapeutic drugs are able to cross and cause cognitive problems and neurotoxicity, right through to sort of early and middle stage clinical trials evaluating various supportive care interventions like medicinal cannabis or fecal microbiome transplantation. So really, really diverse projects in my group, but ultimately we very much are united by our shared goal of improving both the physical and mental health of people affected by cancer. And so I think probably from me describing my area of research, you probably can appreciate the importance of consumer engagement in ensuring my research program is actually addressing the true unmet needs of people affected by cancer. I think, you only need to go to the literature and compare the rates of adverse effects that are reported by clinicians versus those that are reported by patients. And clinicians will rate things quite low on the intensity scale and on the problem scale. They'll grade them from 0 to 4. And if you compare that to the rate and the severity of these symptoms when they're reported by patients, they're much higher. So clearly, simply by asking patients how they are, we get a much clearer picture as to how big the problem is in terms of symptoms and side effects of cancer therapy. And that's absolutely no disrespect to the clinicians providing care to these people. It simply is the fact that people engage with the healthcare system so infrequently when they have cancer. They're often getting chemotherapy in an outpatient ward. They have very little face-to-face contact time with their clinical care team. And so symptoms and side effects get missed and they get swept under the rug because people are a little bit embarrassed to talk about them, particularly things like diarrhea. People are also worried that their chemotherapy may be reduced if they talk about it too much. And so I think that for me has been a clear and driving force as to why engaging with people with lived experiences is so important in my area of research. I can't just assume what the problem is. I must talk to these people to appreciate exactly what they're struggling with and what these areas of true unmet need are. And I think beyond that, a lot of our work engaging with patients in this area has also been about understanding how we can measure these symptoms and side effects more effectively and more meaningfully. Again, a lot of trials that are evaluating various interventions for the side effects of cancer treatment. They use clinician-reported outcome measures to assess these symptoms. And I think, based on what I've already said, there are some inherent challenges and limitations of using that approach. And so we've been working with patients for quite some time now and consumer groups to make sure that the endpoints we're using in our trial are actually capturing the problem that we're trying to address and that it's capturing it in a really meaningful manner. So the use of patient-reported outcomes in our trials and combinations of complementary patient-reported outcomes is a really important aspect where we rely very heavily on consumers to help us define what is appropriate, what isn't appropriate, how many questions are too many, how many is not enough, and really how should we be capturing this problem. So in terms of my sort of journey to consumer engagement, I suppose, I was really lucky. I had a PhD supervisor who was very active in this space already. And so from a really young age, research-wise, I was exposed to the importance of engaging with consumers. And so my first introduction was going on a Friday walk and talk with the Cancer Voices South Australia group. Unfortunately, the ringleader behind these Friday walk and talks has since moved interstate, and unfortunately, the walk and talks have kind of dissipated without her leadership in this space. She used to really rally around us and make sure we got out the office on a Friday and went for a walk. But that was such a nice experience because it would be a group of Cancer Voices consumers, some of which were patients, some of which were survivors, some of which were carers. And then there was probably anywhere between 5 and 15 researchers that would join each week. And it was just this really informal, we weren't there to talk about a project or to talk science or to talk problems, but naturally through our informal conversations, we kind of navigated through some topics that were relevant to various research projects. So since then, I've really started to, I guess, take my involvement in consumer engagement a little bit more formally. I now sit and represent the University of Adelaide on the HTSA consumer engagement group, which has been really excellent to work with and be involved with. And I also chair an international society called MASC, which is the Multinational Association of Supportive Care in Cancer. I chair their patient partnership committee as well. And so this has provided me with an opportunity to really inform global standards and protocols, I suppose, for how societies can engage with people with lived experiences. So we've introduced new registration categories, new membership categories. And so up until only a few years ago, we never had a consumer unless they also wore another hat as a researcher or a clinician. We never had these people who were coming to our meeting. Last year, we had just over 20 consumers who attended the meeting, which was just, it added this layer of this different dimension to the conversations and the discussions that were happening. And it was just such a positive experience for me to have that. So in terms of the benefits specific to sort of my day-to-day research, I think really, it's funny because I'm predominantly a lab-based researcher. Yes, we do some clinical trials, but I would say the bulk of my research is either in vitro or in animal models. And so I always have people saying to me, well, do you really need to engage with consumers in this sort of preclinical context? What use is that? What are you learning from that? And I think I always challenge people who have that assumption and emphasize that, ultimately, we're all working towards something that is going to be in the community, in people's hands, bodies, etc. And so if you're not thinking about those elements back at the preclinical phase, you're really missing a major part of your program development. And so a specific example, I think that where I've really learnt from consumers and applied that to my preclinical work has just been around this concept, I suppose, of appreciating how various symptoms and side effects interact with one another. It's very rare that somebody gets one symptom or side effect from their chemotherapy. They're going to have 2, 3, 4, 5. And what I never appreciated prior to talking with consumers was the interrelatedness of these symptoms. You have diarrhea, you stay up at night because you're going to the toilet every couple of hours. So then you're fatigued. Then the next day, your cognition is not so good. So then that next day, you've got to have a day off work because you can't properly understand, or engage in academic conversations at work. So then the next day, you're depressed. And, up until that point, I and many people in the field really had this siloed view of these different symptoms and side effects, which is terrible because that's just simply not how it happens. And so I've really taken that approach where we appreciate these symptom clusters, and I have implemented that into my work. So I used to be very, very siloed on gastrointestinal side effects, and I now have projects that span from cognitive problems to skin problems to mouth problems, gastrointestinal problems, immune problems, because they're all one in the same thing. And if you're not addressing one, if you're addressing one, you've got to be thinking of the other and how these interact. And that was really a piece of insight that I gained from talking to people with lived experiences. And I think, that really extends from the physical to quote unquote non-physical symptoms. The sort of interrelatedness of physical side effects and sort of mental health challenges has also been something that I've really appreciated from listening to consumers. And we had one particular guy who came in one day to one of our morning teas, and he said, why aren't you doing anything about mental health? everyone cares about how my liver's functioning, but no one cares that I'm, depressed. And so as a result, we put together a project for the MRFF consumer-led scheme, and we were successful. And this all came from a consumer's idea. So that's absolutely my success story of consumer engagement so far.
Oh, that's great. And that's another example of a consumer-led project there. So thank you. I really like the idea of the informal, no pressure Friday walks as well. Yeah, really great to build those relationships. Thanks, Hannah. All right, so now I'm going to ask a question for Shyam. So Shyam, I'm aware that you started your journey in health research as a health consumer yourself, and then you transitioned to being a researcher, straddling both roles, so that consumer and that researcher, you do both. So could you please explain how this process came to be and how you go about navigating these dual positions or dual roles?
Thanks, Sarah, and it's great to join with the fantastic panelists today. And I would also like to acknowledge that the work that I do is people with lived experience, and I would like to acknowledge their time and their contribution to the research as well. So as Sarah mentioned, I started as a consumer with lived experience. I had a kidney disease and a kidney transplant. And what I noticed during that time is even within kidney disease, 80% of the clinical trials failed to address top 3 patient priorities. As Hannah mentioned, there were a lot of misalignment, and we need to reevaluate how do we do research. That means focusing on our methodologies as well. And also it's ethically being responsible, because most of the funding like an HMRC and an MRFF are through taxpayers. So it's crucial to ensure that the research that we do is from a patient perspective. And I currently work within Central Adelaide Local Health Network, and I'm the manager for consumer engagement and health promotion for South Australian Prison Health Service. So when I looked at my journey in terms of being a consumer with a lived experience and the transition to the health system, we all acknowledge and that the health system is a bit dysfunctional in terms of health patient centricity, because I am a huge advocate for systemic change. And in my opinion, there are only 2 ways where you can change a system. Either you have to work within the system and or step outside and advocate through protest and rebellion. So I decided to infiltrate the system and bring a meaningful transformation in the work I do, because a lot of people want to do consumer engagement, but it's so hard to provide value or justify why we have to do consumer engagement. That's where they struggle in terms of how do you address that adding consumers to your research brings value. And for example, Paraxel, which is one of the consumer organization in US, they have done research study on the impact of consumer engagement. For example, in patient-centric trials, they can see there was a patient recruitment that happened more quickly compared to a traditional trial, which takes 7 months to recruit 100 participants. But if you put patients at the center and ask them the right question, the recruitment rate went to 4 months. So there is solid evidence in terms of engaging consumers early, as Gillian mentioned, not just in the dissemination phase, but setting priorities as well. And when I stepped into this role, and which I see a lot of people are now being empowered to be a lived experience advocate and also given full-time positions, I just wrote a LinkedIn post saying consumer engagement happens by choice, not by chance. It's a conscious choice by serious leaders in this field to create roles and positions within these health networks to have people with lived experience to be embedded in these organizations. So I was fortunate enough to work under one of the leader, Professor Stephen McDonald, who employed me as one of the consumer engagement officers for ANTS data, which is a registry with collect data from people with kidney disease across Australia and New Zealand. So from there, I started my journey as well. And there are 4 or 5 key things that I'm going to share with you today. The first one is acknowledging our biases, because when I first step into the transition, and I want to be aware of where my own biases are from a health consumer perspective. I had a personal experience, but also it is how do you influence the policy change? How do we influence the research from the other side? I have a PhD as well, and I do know there is this publish or perish culture in research, but how do you balance that gap? And also the next point is embracing the slow pace of change. I quickly learned that the change in healthcare and research does not happen overnight. It is a gradual process and often laden with a lot of bureaucracy. But when we are in this system, it is important just to take time for these processes to happen rather than being frustrated or burnt out, because I'm a strong believer in keeping these sustained momentum throughout the projects because we are in for a long marathon, not for a sprint. So I was quickly aware of the change which happens very slowly within these organizations. And then the next one, which I struggle, even though I had a PhD, is gaining the credibility of the researchers, because one of the significant challenge was these, when we work with professionals like doctors, nurses, and medical researchers, they bring a vast array of hard skills and knowledge to the table. Whereas when you're a consumer, even though if you're a CEO or a lawyer, your skill sets are different. And also, how do you talk to them or engage with them on an equal footing so that they don't, you have a table at the seat, but you don't want to be a quiet person sitting there just listening to them. You have to be able to voice your opinion, bring a systemic change through your ideas. So it's about gaining the credibility as well. And for that, I need to develop a lot of skill set. For example, how does this scientific process work from bedside to or from bench side to bedside? So how do you bring the consumer voice from bedside to boardroom? So what are the mechanisms that are in play here? Who are our stakeholders? Who are the people who can make effective change? So how do you communicate with them in a meaningful way? How do you communicate with the patients as well? So there are 2 ways of communicating to the researchers and to the patients. So you have to wear multiple hats during this challenge. And continuous learning and adaptation. I learn from my peers. I learn from a lot of mentors, and I do have communities of practice. So it's a continuous learning, and because the health care landscape and the research landscapes are continuously changing and evolving as well. So how do you make sure you as a consumer are up to date on these changes, which will help you in your organizational capacity? So I feel fortunate to be in this position where I can make a systemic change, because I'm all for changing the culture of a system rather than changing policies and procedures, because that's where true consumer centric research happens. Because even though we have accreditation, we have quality governing boards, but at the end of the day, it's people who work with people in terms of creating trust, being kind and compassionate, and being mindful as well, so that we all work together to bring this change. Yeah, thank you.
Yeah, thanks, Shyam. I really like the first one about acknowledging our biases. You know, it can be really tricky to step outside of that. So thanks for that insight. And then Mario, so you're the last one, lucky last. So Mario, you're our consumer rep on this panel. Can you let us know a little bit about yourself, why you wanted to contribute to research, and what's been your most meaningful contribution from the other side? Thank you.
Thanks, Sarah. And I feel really privileged to be amongst this group, but I'm not up that level. I'm a lived experience person, but what the other panelists have been talking about is like music to my ears, and I'll probably highlight that later after I've given you a bio of myself, of why I'm into all of the research and what I do today. So basically, bit about myself. I was given 5 months to live back at when I was 15. I had Hodgkin's, and back then it was you had a less than 5% chance to live. Obviously, I'm still here 48 years down the track. I also had a second cancer diagnosis at 35. I had a triple bypass at the age of 38, and I had a valve replacement in 2018. I've experienced the health system then from the inside out. I also have had a child diagnosed in 1995 with intellectual disability, and then down the track in 2015 losing a daughter aged 26 to a lifelong mental health issue. I've been passionately using my time and lived experience to find the gaps and break down the silos in the health system and ably assist in research projects. So briefly, I have an extensive knowledge and experience in information technology after 38 years as a IT technical consultant for finance and business sectors. I've been an avid volunteer, event organizer and fundraiser with a range of charities, hospitals, grant committees and community groups for over 25 years. I'm a consumer advocate for a range of organisations, which was mentioned before, including research institutes, universities, local health networks, non-government organisations, to name just a few: Women's and Children's Health Network, CIH, Breakthrough Mental Health Research Foundation, FIMRI, and obviously also ROSA, which is Gillian's heads up there. I currently now work 2 days per week at the REPAT as a lived experience carer consultant in the Salem mental health space, as well as participating in many community programs, health committees. I also produce a mental health and wellbeing podcast on community radio, which is Radio Italiana 531. I am also a multi-award winner of community service from newspapers, radio stations, and financial institutes. Amongst all of that, I still also do a gym program called Strength for Life, which is from Caughey. And this is, I do that twice a week, and it's for the aging community for over 50s. And I'm a qualified mental health first aider. So why did I want to contribute to research? That's $1 million question. But so obviously, due to my own personal life-threatening conditions and those of my family, I have a thirst to help researchers come up with better solutions. So I feel privileged to still be here and to be able to do what I do every day in building networks, breaking down the silos of health to help deliver better outcomes for consumers and their carers in both health and research. It must be remembered, people with lived experience of disease or ill health, physically and or mentally, hold invaluable knowledge and unique perspectives for medical research. For example, cancer survivors, people living with Parkinson's, those managing chronic conditions, people with experience within a health system or support people such as carers of a person with a medical condition, bring important insights to research that can benefit clinical, health services, and basic research projects. As the consumer/caregivers of healthcare, people with lived experience have the expertise of what it is like to have a health condition and interact with healthcare services. As a result, consumers hold a critical perspective in the progress of identifying research priorities, conducting research, and communicating findings with the public. And basically, I'll show probably a diagram right at the end of after I've said what we've got into, and I'll probably highlight some of the things that all the other guests have talked on there, which everyone has mentioned something that's hit me, which we've got in common. So what is my contribution? I've obviously been on a lot of research projects in the cardiac space, obviously. I even did one with the effects of what Hannah had before about mental health within cancer, such important. And that's one thing I actually highlight a lot out there, that even though you have a physical condition, what is the mental health aspect? I'm very, very strong on the mental health side of things. Frailty, so obviously from the aging, and obviously with my involvement with ROSA, etc., it's such an important thing of as we age, you know, that we get obviously frailty there, but doesn't mean that you have to be that old. It's just how you take care of yourself and what you do to your body along the way. But recently I was involved in a successful MRFF grant. It was as a carer providing input into a parental alcohol supply research project for children, really. It was for children between 12 to 18. And it was interesting because it was for 12 to 18. But the thing is, majority of people potentially just think, oh, yeah, just don't have the alcohol within the household. But that's not the solution. The solution, there's many other things to the solution. There's behaviors. There's also the friends that they may have, etc. And then there's the other concept of having zero alcohol and what that is actually starting to bring on society. So it's really, really important that we got to remember that we have to think outside the square and not just assume things. So as I was saying before, everyone has touched on something. Obviously, Carolyn was talking about, obviously children with pain, not knowing where to go, finding that central point. It's something that's really out there a lot still. Obviously, Gillian has brought in what some people tend to think that consumers are the people that actually just suffer, but what about the carers? The carers are so important. They are part and parcel. They're there the other 23.5 or 23 hours of the day or whatever time that they have between sessions. Obviously, Hannah bringing along about the mental health within cancer. And that's something that really, really gets to me because cancer is, it's being obviously affected myself from 48 years ago and knowing, am I going to still be here today? And what mental health effect it had on me and trying to be resilient about it. And obviously Shyam as well. I love what he said about having that involvement within, do you work outside, which is what I was doing as an advocate, or do you get within the system? And hence, I am now in the system. I'm actually working within Salin mental health. It's because the only way you're going to make change is by being in there. And and also obviously about the culture as well. It's something that we really, really need to press ahead. And we need to really make sure that people are serious about the lived experience factor. And I'm not talking about the researchers here. I'm talking about, the politicians and the people that are making all the rules, etc. Lived experience needs to be taken much more seriously and its involvement in everything we do. So I just want to share something at the end here, and hopefully this works for you. Actually, hopefully, slideshow. I don't know if that's working. Can you see that?
No, not yet.
Can you see it?
No.
No? Okay, sorry.
I can try. That's all right. I'll try sharing from my screen, Mario.
Thank you.
Sorry, just a second.
People are going to say, what's up?
We're getting there. All right, we're there. Thank you.
You got to go back one screen, Sarah.
There you go.
Okay, so this one here is something that, so you see the parents on the side, which are people from the outside. They obviously see the mobile and say, hey, this is great, and, they all agree that it's working great. But down the bottom, which is the consumer carer, etc., they obviously the consumer is actually seeing it in a different way. And that's what we always got to remember, that don't assume that, just because it looks great, it's what they want. Remember to ask the consumer and start from the beginning, not partway through, etc. And so if you can go to the next screen, Sarah. So co-design is so important, obviously. Obviously, it can be messy, but if it's done properly and it's done from the beginning, you get great results. And that's what it's all about. You need to remember to co-design and do it from the beginning. Thanks, and hopefully I didn't take too long there, Sarah, but...
No, No, not at all. You started by saying you didn't think you're up to the level of everyone else, but I'd argue you very much are, Mario. So thank you for sharing that with us. And, you know, like you said, everyone has their own perspective. So your perspective is very valuable, and that it really mirrors from the other side what everyone else was saying. So thank you, everyone. And now we're up to the Q&A portion of the session. So if anyone who's tuned in today has any questions, please pop them into the Q&A function. So feel free to do that at any time. I might just start getting the questions off with Caroline. Carolyn, you mentioned you're obviously recruiting adolescents to some of your projects. I could be wrong here, but I imagine there's unique challenges when you are working with adolescents. They're in school, they've got their studies, they may just be part of less groups or more difficult. There may be ethics issues. Have you noticed there being some specific challenges to adolescents recruiting them, and the advice you would give to others who want to work with adolescents on their research projects?
Thanks, Sarah. That is, yeah. Essentially, that's been the most challenging that I've found about this whole project, is actually trying to recruit adolescents. And you're right, there are consent issues, there are parent issues, there are feasibility issues, there are ethics issues. And using university ethics is one thing, but actually wanting to recruit some from the Women and Children's Hospital means that you need to get Women and Children's Hospital ethics as a second option. You also have to make sure that you're safe, providing a very safe environment if you're going to be interviewing or even have a co-design sort of workshop going on. So you need to budget a little bit more when you're designing kind of co-design research with adolescents, because you actually need to have at least one facilitator and then a couple of people who are happy to watch or to be secondary facilitators with that workshop. And and make sure that up front you take all the contact details that you might need, lest anyone becomes disturbed or distressed really about some of the topics that you might be hitting on. So it comes back to both Hannah and Mario were talking about physical and mental health, and you never quite know when you're talking about someone's physical health, so their chronic pain, whether you might stir up some emotions that are actually hard for them to cope with at the time. And so if you're just one person facilitating a co-design, it's not really a safe environment to be in. So I've learned a lot about distress protocols and making sure that we have safety processes in motion. The second thing about trying to get adolescents is trying to know where to find them, because in actual fact, if you can try on Instagram, which you might think is kind of a good base for attracting adolescents, but they've got pretty good antennae, and they're pretty resistant to joining up to anything that doesn't sound like it's going to be good for them. So one of the things about engaging adolescents and within our project has been trying to work our methods around so that what we do is actually really engaging and gives them back quite a lot of support and empowerment at the same time. So it may be a kind of co-design workshop that would also instill within them some skills for self-advocacy, or help them grow in some of their development, like assertiveness at schools, those sort of things, so that they can bring the problem and they know how to have critical conversations with people. So it's not the co-design would be great if, you know, you're just extracting information, which is not what co-design is all about. But, you know, there has to be a slightly better design than we have, so that we incorporate creativity and engagement and enjoyment within those co-design workshops to attract and start maintaining and build trust, those longer relationships. As you said, Shyam, you're in that for the long term, so are we. So it's a matter of really developing that trust and showing them that we really do care about where they're at and meeting them at their spot. So there's some of the things that have been challenging for us.
Oh, that's fantastic. Thanks so much, Carolyn. Jill, you were talking about having consumers embedded with all of your projects from start to finish. A question I get asked often is about reimbursement. So where do I find the money to reimburse my consumers? And so I imagine there is, you know, a decent amount of reimbursement funds required for the level of engagement that Rosa's undertaking, which is, it's very advanced as well. I imagine you're also building some of these costs onto your grants as well. Can you give a little bit of insight as to how you navigate reimbursements? And some of the question I also get asked is pre-award of a grant, how do I find the money if we're co-designing what questions should be answered? And maybe that's a bigger question. But before money's already been awarded, how do we get those funds available? If you've got any insights in that space, that would be useful. Thank you.
Yeah, thanks, Sarah. I think, something that's really important is to respect the consumers as an add value. And so obviously with all the grants that we write, there's budget lines written into that in terms of providing appropriate support. So it's not just for attending the meeting. We, budget to allow them to have sort of reading time of the material before our meetings. And then also all of the other translation activities is also budgeted into the research grant. And when we were established, we had that budget line there included within funding for Rosa. So we were really sort of, fortunate in that regard, is that there was allocated and dedicated money to support really active consumer engagement of our researchers. And importantly, there's SA Health have recommendations about the level of support in terms of financially how much money you should be paying to support consumers. So that, there's always that's a good place to look and start. I'm not really sure in terms of if you've got a great research idea and you want to have those conversations about where it comes from, but I think it's just really important that in everything that you do, that you have that level of consumer engagement throughout. And it might be, you might just have to have a coffee with the consumer to start off that conversation. I think that's a great place to start. And again, we keep coming back to the importance of having a relationship with the consumer. It's not just a end user, if you like. You need to have them building those relationships, and that sort of will then, hopefully grow that collaboration, because we really do see it as a collaboration with our consumers when we do our research. So,
okay, great, thank you. So one of the questions from the audience, I don't know who this is for, but if anyone feels they would like to answer this one, are you familiar with any formal frameworks we should be using for consumer engagement? Or is it okay to have consumers as part of your research team and work together on the key aspects outlined as per Mario's slide?
I think, the NH and MRC, so they sort of have guiding principles and a framework for good consumer engagement. And so that's obviously the peak funding body for health and medical research in Australia. So that's a really great place to start, I think, and they've spent a lot of time developing that consumer engagement framework. We've developed one specifically for our research centre at Rosa, and I think it's really important to make sure that to do consumer engagement well, to start off with having a terms of reference. What is it that you want to achieve through your consumer engagement? And it has to be a mutually two-way kind of thing. And so what are consumers going to get out of their involvement in your research as well? So I'd encourage when you're starting to do your consumer engagement to develop a terms of reference, develop that framework, and base it on what's recommended by the NH and MRC. It doesn't have to be a lot, but it means you'd really put that thought into what is it that you really want to sort of do to provide that meaningful change in terms of your consumer engagement.
Yeah, great. Thanks, Jill. Is there anyone else that wants to add to that?
I think it's just as well, like we've reiterated several times throughout today's session, has been that informal nature. Like, yes, absolutely go to these guidelines and make sure that we are following appropriate recommendations on how we should approach consumer engagement as per best practice. But I really feel the benefits that I've gained from consumer engagement have been the informal activities, the Friday walk and talk, the casual coffee. And I think that creates this level of I don't know, it just removes the formality of it. So it feels like you're actually friends with these people, which I am, as well as engaging with them in a formal environment. And I think that can be a win-win, you know, thinking back to the previous question about how it can be challenging to do this initial workup if funds are tight, if you haven't been awarded that grant yet. My experience with consumers is that on the whole, they're extremely understanding and very reasonable people, and they will appreciate that at the get-go you don't have a lot of funds behind you, and they will appreciate just going for a coffee together. So I think making sure that we marry these formal approaches to consumer engagement with these informal relationship building exercises is really critical and also cheap. It doesn't take much just to be a nice person.
Thanks, Hannah. Shyam just shared some resources within the chat. We also have on Health Translation SA's website, we have a toolkit where there's some resources. There's a draft terms of reference that people could use, and also the Western Australian Health Translation Network. They have developed a guidebook for the starting points as well. So after this, I can circulate a whole heap of resources to everyone who's tuned in. And sorry, Mario, were you about to say something?
Yeah, I just going to reiterate back on what Hannah was saying there about the informality, and their bottom line is make sure you're keeping it simple, because not everybody is of the level of, you know, got the understanding, you know, the language, etc. We're talking about culturally linguistic diverse. We're talking about First Nations people. We need to make sure that everybody, it's an inclusive process, not just an exclusive process, so that we are covering a whole range of the population, etc. So keeping it simple and making sure that you know, I get overwhelmed with a lot of all the policy stuff and forms and etc. because it's sort of like I don't need to read it. When you've got people that are in a sort of a situation of recovery or whatever, the last thing they want is to be reading a massive document or not really understanding everything about it. So sometimes let's keep it simple, and you know, we're going to get more involvement. Thanks.
Thank you. Carolyn, your hand's down now, is it?
I just put up a resource in the chat box as well for youth, engaging with youth, wellbeing,
Fantastic.
health and youth. So.
Okay, great. Thank you. You touched on Indigenous populations just then, Mario, and the next question from the audience is, how do you promote good engagement with Indigenous populations? Now, does anyone on the panel have experience with this?
I think in my area where we work with kidney research for Indigenous population, the first key guidance is to work with Indigenous researchers and champions in that field. Don't assume. It's obviously we will make some mistakes, but be brave to make those mistakes and learn from it, and be a true ally to them in their causes. Across the things, for example, identifying systemic racism within healthcare, acknowledging there is a systemic racism, go hand in hand with their political fights as well, because it's not you can pick and choose your research, because when the research with Indigenous organization comes, it's more about that whole social determinants of health, how it affects them, have that big picture rather than very specific area about your research, because I always say you have to build trust at the speed of a relationship, not at the speed of your grant cycle. Because if you just want to build that, it's never going to happen, because we often have this idea you can just send out an expression of interest for 10 Indigenous consumers to be a part of your research. That will never happen, because this trust takes so long. Trust always comes in a turtle and leaves in a horse, because it's so important to build the trust factor. And to do that, take a step backward, work with your Indigenous champion, ask them, because I once held a kidney research priority setting workshop in Picavia, which is in Port Augusta. And the first thing I did is to identify some champions who are working with a not-for-profit. I gave them the agenda, I worked with them, and then they took the lead. Be brave to take a step backward and ask them to lead into their, just hold their hand, and they are happy to lead you into the system, because it takes so long to build the trust. But once you build the trust, they will be your champion. Just it's same with any multicultural communities as well, because people are often get fearful, or people are often silenced in this healthcare system because the countries that they came from are more paternalistic. They are not very inclusive. So it's about giving them a voice. And once they found their voice, they will just advocate not only for your cause, but their cause as well.
Thanks for that insight. Does anyone else have anything to add to that?
Just wanted to say,
Sorry, you go, Mary.
mine's a quick question, quick thing. I haven't had any dealings with the Indigenous within the research, but I have at the hospitals. They've got their own Indigenous group which provides input to women's and children's. But from an aspect of the Indigenous have their own medical system, as in the way they think that, and that's getting that understanding. So enabling you to combine their beliefs in what their medical practices are with the Western world, basically. So that needs to be taken into account.
Yep. Jill?
Yeah, I just add that we've got a research program that we do with Wardill here at SAMRI, where we look at quality and safety of care provided to older Aboriginal people in the aged care system. And importantly, this work is led by Aboriginal people. So we established the Rosa Aboriginal and Torres Strait Islander Committee. So it's got nationally representative committee of people that are Aboriginal, and they drive the research agenda, the research priorities, and it's done under the sort of, Aboriginal data sovereignty and governance. So I think, it is really important that, it's their research for their people, and it's, really important that we, have like cultural appropriateness, as Mario highlighted. So, I think, we do research with them, not on them. So I think that's really important.
Yeah. I've just got a couple of things to add in that space. A lot of the organisations, especially the universities, they'll have an Aboriginal unit where employees can go to for guidance in the first instance. Also, again, like you mentioned with Wardill in SAMRI, they have worked on a framework for how to do Aboriginal research the right way. They also have just launched a 2-day course. I think they just held the first one in the last month, where they talk about a lot of the ways in, if you're Aboriginal or non-Aboriginal, the best ways to engage and do Aboriginal research the right way, like the name implies. So I would encourage you to go to their website, and I can see if I can share a resource on that as well at the conclusion of this. The next question, how do research groups recruit consumers and community members for all the activities they lead? Are there different avenues, and do the same community members tend to raise their hands? I think this question can probably go to, Gillian, Carolyn, Shyam, and actually probably all of you can take your turn in answering this question, I think, as to how you individually do it. So, Hannah, did you want to start?
Sure. So I think certainly something that works really well for me is identifying sort of advocacy organisations that already exist and who have a large pool of consumers that you can engage with. Because something that I certainly find is that there is a tendency to have the same people raising their hand all the time. And it's not necessarily that, they're trying to be the loudest in the room. It's just that you do have these people who tend to, like we do in any scenario, right? I think any media activity, the university seems to go straight for me. I always say yes. So I think, naturally we do get the same people wanting to put their hand up and wanting to help and wanting to be engaged, which is really great. But it is, we do need to be careful that we're not always listening to the same voice, because as we've mentioned so many times today, everyone is so different. And so we need to make sure we get diversity in the perspectives that we collect. And so I think engaging with advocacy organisations that can advocate on behalf of consumers is a great start. They tend to, that at least gives you a broader brush sort of perspective initially, and then they can then tap into their large sort of mailing lists or networks of consumers that they engage with. For me, in my area of research, that means I'm engaging with many different advocacy organisations, from Breast Cancer Network to Myeloma Australia to Cancer Voices. There are many. I think the downside to that approach is that you don't necessarily get such one-to-one engagement with individuals. And so to sort of supplement the work that I've been doing where I engage with these organisations, I have tried to start my own sort of, I guess, consumer group associated with my lab. And so what I've got a QR code that I put on every presentation, every poster, any sort of any community-facing activity that I do. And this QR code will take people to a Google form where they're able to register their interest to stay connected with my group. This may be a consumer, it may not be a consumer. Chances are, given how prevalent cancer is, they're a consumer in some way, shape or form. And so this allows me to sort of, I suppose, passively connect with people who are interested in my research program. And I then send out quarterly newsletters with updates from the group, with opportunities that may present. And it's a way for me to keep a list of people who are engaged in my type of research. So they're sort of the two strategies that I use the most. And I've also used the HTSA registry as well, which I think is a really good strategy as well.
Oh, great. Thanks, Hannah. What about you, Jill?
Yeah, we, to do our recruitment for our new consumer system, I think it was last year, we used Health Translation SA, we put together a little bit of a brief about what the involvement would look like. And then we also circulated it with SA Health, the older persons. They had a big mailing list of people, so we were able to recruit through that, and also through CODA SA, so the older persons consumer advocacy group. So I think in doing that, we had it was quite overwhelming actually how many people registered to an interest to be involved in ROSA. I think there was like about 65.
Oh, fantastic.
Yeah, we had 4 positions. So, obviously that really got out to people, but I think, Health Translation and SA Health were really the main sort of spreading of the word about this. So.
Great. And Carolyn?
So advocacy groups, I agree with Hannah, they're a great way to go. And within youth, there's the Child and Adolescent, the Commissioner for Child and Adolescent Health. And there's also other advocacy organisations like youth advocacy groups through Women and Children's Hospital, through, surprisingly, councils. So councils are actually a really good source of community engagement with youth. And then libraries, which also might surprise people given the amount of social media that's around, but actually they have very good internet. So often, and if you time it, the thing that we've found is timing is, if you're interested in recruiting youth, you need to be timing it to their holiday period, because as you were mentioning before, it's a bit tricky for them to measure up to school plus committing themselves to projects like that we've got going on. So it's actually great if you can time your approach around a time when you know that they've got a bit of extra time just to think about the options and to think about whether that's something they'd like to contribute to. And we are also following up with sort of research design groups, so making that longer term. The people that have shown interest in staying on longer term, they'll be on a research design group that will keep going with the university, and again, quarterly newsletters. So it's a very similar sort of style to Hannah there with those things. And I think they were the best places for us, although we were advised to go on Instagram and the social media to try and get people. That it was very interesting in doing that, because it actually brought a lot of people to the table who weren't necessarily appropriate to our study, and because we were offering a reward, or a payment remuneration for actually contributing to the study, we had to find a way of sorting them out, because this was a South Australian only study, and we had lots of people from United States, from Africa, from all over the world, and they would just put a postcode, because that's all we were asking for, was a South Australian postcode, and then we had to have little interviews to try and work out whether they were actually from that postcode or somewhere else. So yeah, it can be a bit tricky depending on where the information lands.
So social media with caution.
Yeah.
Shyam, do you have anything else to add apart from what's been mentioned?
I think it's all mentioned, and I always say, although the SAMRI is a beautiful looking building, no one is standing outside waiting to put their hand up to be a part of the research group or clinical trial group, because we can't expect consumers to come to your organization. You have to go out and meet where they are. That's where these community organizations that Carolyn mentioned, libraries, we have to come out of our fiefdoms and go and meet people where they are. Do some work with multicultural organizations, go to the multicultural groups where they are meeting in the festivals and RSLs. Those are the areas, because we are comfortable in our own area, which is often no one is waiting, excited to go for a clinical trial. And because remember, these people are giving altruistically. There is nothing, and the first thing when we ask them to sign on our forms is, this trial won't benefit directly to you. But still, people put their hands up, literally giving their blood and sweat every day to these clinical trials. And the least we can do is meet them where they are.
Yeah, that's a really great point. Thanks, Shyam. And Mario, do you have anything else?
Yeah, look, I'm a person that I don't like duplication, and there's a lot of duplication that goes on throughout outside there. So there's a lot of confusion. So, and that's why potentially people get fed up or don't want to be part of lists, etc. I'd like to see more collaboration. So between places like for argument's sake, I'm with FIMRI. I'm also on Health Translation SA. So I find that really good that they actually collaborate together, so that they're looking for someone at FIMRI. It goes on the Health Translation. So it's a saturation. So you've got the central point. And I'm a big believer in succession planning. And the reason I say that is because I don't want to be doing what I'm doing for the rest of my life. I want to make sure that I'm bringing up the next level of the consumer carer. And that's what I'm doing also within, or trying to do in the health network, even though it's not working at the moment because there's barriers. Again, I've been serious about lived experience, values, etc. One of the things that I had was that the HCA was a really great organisation where it actually taught consumers and carers the art form of how to be a good consumer carer. And I'm not saying nobody's a good consumer carer, but it's teaching the people of how to present themselves, when to talk, when not to talk. Because a lot of the times we're talking about emotional things here, and it's how to express themselves. So it taught me a lot. Unfortunately, it got disbanded because, again, it's a government thing where they removed funding, where I think it was very, very beneficial having something like that, because it was an actual place which was a central point to being able to get good health consumers and carers. So, but as I said, HTSA is really good because a lot of opportunities I see through that. I mean, for us, like in the mental health space, like the OCP, which is the Office of Chief Psychiatrist, it tends to post other people's expression of interest, etc., which is very, very important. So one of the biggest barriers that you have is the confidentiality side of it. That's why a lot of times people can't share data. That's what I found at the moment, trying to get mental health people within the silent space, is because I can't touch the OCP's data because it's confidential, even though we're all under SA Health. So in the end, we just we need central points, and that's the best way of saturating out there. So you're going to touch someone. Thanks.
Yeah, thanks, Mario. And just a couple of additional things there. When researchers come to us wanting to recruit some members, we often do a bit of stakeholder mapping. So find out who are the groups, and whether it's the advocacy groups that we've mentioned, your clinical partners, they have patients who have the lived experience that you're looking for. There's a whole host of registries around the place, some within the local health networks and the health translation essay one. So there's often not one place, but it's a bit of a putting the feelers out there and working collaboratively with the people that you do work with. I've just got one final question, and if anyone has an example of this, feel free to answer it. So we've heard some success stories, but are there any non-success stories? So from anyone who's given consumer engagement a crack, something didn't work well, and what you learnt from that. Does anyone have an example they want to own up to here?
I'm happy to start with maybe not a non-success story, but certainly a challenge that I faced. This was in a project that I did last year. I just found it, we had excellent consumers. These guys were just a dream to work with for most of the time, and were so giving with their insight, but they were so inherently connected with the study and responsible for, this was through a funding call that specifically was for a consumer-led application. So this is not like the MRFF one where it's they say consumer-led, but ultimately the CIA is still a researcher. This is truly a consumer-led project where the lead applicant must be a consumer. And so something that we found really challenging was he was so enthusiastic, or this team was so enthusiastic. We found it really challenging to know or to marry his expectations and their expectations with what I potentially could call sort of good scientific rigor. You know, and this comes back to these differences in expertise. He had excellent professional qualifications, a very professional, very high-flying person, but necessarily those skills didn't translate into a good understanding of good scientific rigor. And so the way in which they saw the program or the piece of work unfolding was very different to how we saw the piece of work unfolding. And so we found it really challenging to kind of remain respectful to the consumer-led idea, but also make sure that what we were producing would stand strongly in the scientific community and potentially the published literature. So, you know, not necessarily any solution from this, but I think it's an important piece of learning to probably set out expectations earlier than maybe what I did in that study and in that experience. And it was really a big learning curve for me to understand, to learn how to navigate sort of that fine art of negotiation around, you know, making sure that I respected what the consumer wanted and how they saw their vision for this project coming to life, but also guiding them in a way that made sure that what we were producing and spending, you know, considerable amount of our time doing was going to be truly beneficial. And that benefit really came from it being designed rigorously. So that was certainly a challenge that I found. I don't know what the solution is, but probably just better communication.
Thank you. And anyone else? No?
One of the often asked question is from the researcher is to provide that evidence that consumer engagement brings value to their research, which we as a practitioner and as a consumer is so hard to provide that tangible evidence. And I find it really hard. And that's where most of it's not a success story. That can never be a success story because we do try to do it every day, the best of our abilities, but there is always a room for improvement. But that appetite for that consumer engagement brings value, and what sort of value, that questions are the ones that sets this notion backwards. So I think for researchers to be more and more brave and to embrace this and to do this without expecting us to provide a tangible value, that's the starting point, so that everyone starts on the same understanding that consumer engagement, yes, brings value. It doesn't matter where you start, whether you start as an inform or level, consult level, or to empowered level like consumer-led grants, you have to start somewhere, and that's where that expectations are met. Thank you.
Thank you. And so we're getting to the end of the session. Is there anything that anyone else would like to say that they haven't had a chance to say? No?
Just want to say one thing, and I know this is probably going to grate a lot of researchers, etc. But from a consumer perspective or carer perspective outside, obviously there's a pool of money out there with the research, MRFF, etc. And a lot of times you're seeing a lot of places trying to do the same sort of research when sometimes if collaboration was happening, it'd be really much more powerful. And I really, because you get a lot of good minds together. Sure, you're not getting maybe the total glory that you want to get, but I would really love to see that collaboration. And I don't know how we're going to resolve that, but I really would love to see researchers getting together from different organizations, etc., because there's things that people have mentioned that I've been actually involved in as well and haven't got the grants, etc., which I think if they probably got together, maybe might have been even better. So anyway, that's just a little bit I want to say.
No, thank you. All right, well, I think that's just about wraps up. I want to say a very big thank you to our panelists. I and I'm sure the audience really appreciate your time and sharing your insight and expertise. So thank you. Thank you everyone who has tuned in. I'm just going to quickly put up our contact details if anyone would like to reach out, would want some assistance in this space. And so that concludes today's session. Thank you, everyone.